Consultant for Asia and Snipe Diagnostics. So let me share with you some important link for your exam and for the training feedback. So please copy this exam link and the feedback link. After the end of the session, you may connect to your final exam link and the feedback link as well, right? So this is the link. So please make the copy of that link. Thank you. So if everyone's joined, so let's start with today's presentation. So I have a brief introduction about myself that my name is Asif Iqbal. So let me introduce myself first in a brief overview of my career that I have done in Masters in Organic Chemistry from University of Karachi in 2001. And can you see my screen? Okay. Yes, thank you. Uh, So I have done my master's in organic chemistry from University of Karachi in 2001. Then I have spent a year as an trainee technologist for one of the leading JCIE and CAP accredited institute in Pakistan. That's the Aga Khan University Hospital Clinical Laboratory. So after spending 4 years as a medical technologist in that hospital in the biochemistry section, then I decided to join the Roche Diagnostics. So, in a Roche Diagnostic, I start my career as an application specialist. Then I am promoted as an customer support manager, and ultimately I was a product manager for centralized diagnostic, and I've spent 7 years in Roche Diagnostic division. Then I decided to join Abbott Diagnostic division, and as an application specialist. Then I promoted as an application manager and NPS coordinator. I also responsible for the quality consortium audit of Abbott Diagnostic affiliate in Pakistan. And I was responsible for these countries like Sri Lanka, Bangladesh, Maldives, and Afghanistan. So during this 10 years, I have an experience of having and responsible for these countries. And then in April 2023, I decided to join SNI Diagnostics. So currently, I'm working as a training manager consultant for Asia, and my reporting is to Ziv and Zui. So this is a brief introduction about for myself. So so let's start with the today's presentation. Today's we have two presentation. One is about the IL-6 and the second one is about immunoglobulins. So let's start with the IL-6. So let's start with today's presentation about IL-6. IL-6 means interleukin 6. So let's start. In today's presentation, we have a four-part. So these four-part contains, the first part contains about the background. In the background, we have an introduction and the systematic effect of IL-6 and their two physiological effect, along with the utilization of a clinical application in the sepsis and rheumatoid arthritis and in carcinoma as well. In the third part, we will discuss about the solution of sepsis as a pro-inflammatory marker of IL-6 and the comparison with the other competitors. And then the last part, we will discuss about some marketing point of view. That's part. So let's start with the background. So as you know that the IL-6 is basically, just give me, okay, now you can see my screen. Thank you. So, you know that basically interleukin is a key mediator of inflammation, and basically is an that as both act as a pro-inflammatory and anti-inflammatory myokines, and as a pro-inflammatory cytokines. And cytokines are basically protein in nature. So this interleukin 6 is comprising of 184 amino acids with a molecular weight of 22 to 27 kilodalta. So it's mainly produced by the immune cells and inside endothelial cells and the fibroblasts as well. So you know that it's act as an both pro-inflammatory and anti-inflammatory. In addition, it's also have a osteoblast secrete IL-6 to stimulate the osteoclast formation. So in the end, it moves to the liver through the bloodstream to rapidly induce an extensive range of acute phase proteins such as the C-reactive protein and the serum amyloids. So this is about the IL-6 as a pro-inflammatory and inflammatory. And as you know that if we talk about IL-6 is pro-inflammatory and anti-inflammatory, it's the one possibility is that IL-6 play a pro-inflammatory action in acute inflammation, but is also exert an immunosuppressive anti-inflammatory action when expressed at the low levels. So IL-6 basically is doing the activation of the beta cells. So if we goes to the next slide, we will share with you in this the systematic effect of IL-6. So if we go to the IL-6 systematic effect, basically as we know that this IL-6 are cytokines in nature, and these are responsible for the diagnosis of the systematic acute phase response. So you know that the first of all, that's when the interleukin cytokines are released, that's an IL-1. That's the IL-1 is basically is an thermodynamic values, and then it's the increase in the blood temperature, the human body temperature during the infections. And then IL-6 is also released from the immune system's beta cells and the T cells as well. So then it's released in the blood streams to stimulate the liver cells to produce some other markers for as an inflammatory markers. So you can see here the third one is the TNF, that's a tumor necrotic factors alpha. These three marker IL-1, IL-6, and TNF alpha. These are the pro-inflammatory mediators, which helps to manage the acute phase and the acute phase response in that. So you can see here the macrophages, endothelial cells, and fibroblasts. That's they release the IL-6 and then has an impact to stimulate the livers, and this liver produce the acute phase proteins like CRP proteins, and these acute phase response responsible for the acute phase response. Also, they release the hepcidin productions just in case of anemia. That's basically increase in autoimmune disease like rheumatoid arthritis and system lupus erythropoietin SLE disease. And this is the HPA axis that's in fatigue, and then a mood change is also released that. In the IL-6, there is also inflammatory markers, and it's also play a vital role in the osteoclast activity and in some the cardiac damages like coronary heart failures and some the strokes, the IL-6 levels are increases, and even in the carcinoma and chronic conditions of inflammations and other conditions which play a very vital role. This IL-6, along with the other markers, play gives you the systematic inflammation response status. So it's also play a very systematic osteoporosis diagnosis along with the probability of fractures in the bones and as well as for the fatigues in the mode. So if we go further for the two physiological effect, you can see here in the physiological effect, there are IL-6 has a two clinical role, and that's an anti-inflammatory. It's bound the IL-6 receptors, and it helps to activate that, and then it's released that activator of STAT3, leading to the intestinal epithelial cells proliferations and the inhibition of the epithelial cells apoptosis. So the second IL-6 is the soluble IL-6 receptors, which is responsible to trigger or activate the immune response and the recruitment of the mononuclear cells, then the inhibition of the T cells apoptosis, and then inhibition of triggers the differentiation, T registration differentiation. So this is the pro-inflammatory markers. So if we say that when IL-6 is elevated, so if we, sorry, good. If we talk about when the IL-6 values are elevated, it's basically elevated in the autoimmune disease in case of any infection. The cells stimulate the T cells, and then the T cells release the IL-6 in response to the inflammation. And then this is elevated levels in case of the autoimmune disease, the cardiac disease, and the in some cases of carcinoma as well. So if you go to the clinical application of this test, so you know that's in case of immune response due to infection, the monocytes has helps to release the IL-6 due to the T cell stimulation, and the endothelial cells also release the IL-6, and it is helps to check the acute phase response of inflammation. And in the sepsis, it's an early marker for the sepsis as well, and it's also in autoimmune disease like rheumatoid arthritis, in the malignant cases like carcinoma. This play a very vital role for the pathological conditions of the different patients. So if we go further for the clinical applications, before that we have to discuss about the IL-6, how it's act on the hepatocellular cells. The IL-6, when released in the bloodstreams, then it goes into it stimulate the liver cells, hepatocellular, to release the C-reactive protein, which is an early marker in conjunction with the IL-6 to give them information about the early stage of the infection. And this is basically through this process. And then it's also released the serum amyloid A and the fibrinogen. And you know that the fibrinogen is responsible for the responsible for the clot factors, and the IL-6 if IL-6 is elevated and the CRP is also elevated, these are the biomarker for the systematic inflammation. So if we talk about the SIDS and the sepsis prevalence, you can see here in this slides that's the 10 leading cause of the death in the USA, and the most common cause of the malignant death is in the oncology is the sepsis. So the severe sepsis occurs in 14% of oncology cases. Around 107 million people get sepsis each year in the US. And if we talk about In journal, the death of due to the sepsis in each year is 270,000 people died due to the sepsis. So one in the three people died in the hospital who have an sepsis is shows that it's an clinically more significant to diagnose this sepsis situation. So if we talk about the samples integrity, we will discuss in next slide about the other samples and the reliability of this test. So in this application utilization, we have a SIDS and sepsis definition. If we talk about the SIDS, so what is SIDS? Basically, yeah, systematic inflammation response syndrome is called SIDS. So sepsis basically is a condition in which the infections has a severe condition according to the ACCP and SCM criteria for the SIDS, basically systematic inflammatory response syndrome. There are two or more. The following criteria meets that the temperature should be greater than 38 degrees centigrade or 90 beats per minute. If the heart rate is greater than 90 beats per minute, then the respiratory rate greater than 20 breaths per minute, or the PaCO2 is 4.3 kPa, and the WBCs are greater than 12,000 cells per cube, or the 10% immature bands forms, that may lead to the SIDS. So if we talk about the sepsis and it's documented as a suspected infection together within two or more SIRS criteria may leads to that's it's a sepsis. So the other condition is severe sepsis. In the severe sepsis, when the organ dysfunctions is associated, which is no limit to that, and the lactic acidosis, oliguria, hypoxemia, the coagulation disorders, and acute alteration in the mental status is an early sign of severe sepsis. The other thing is a septic shock. The sepsis with the hypertension, despite adequate fluid resuscitation and the presence of perfusion abnormalities, who are in inotropic and the vasopressors agent may not be hypertensive at the time when the perfusion abnormalities are detected. So, if we talk about the more clinical utilization, so, in the sepsis case, there are some clinical findings, like if we talk about shivering, fever, or very feeling cold, in extreme pain or a discomfort is also the early signs of sepsis when they have a prolonged infection, or a sweaty skin or clammy skin, or they have a confusion or disorientations and the shortness of breath and the high heart rate. It's suspected. You need to get medical immediately attention if these early signs of chronic infection may leads to the some sepsis. So suspects and the sepsis and saves lives, and which is the best choice to rule out the sepsis is the IL-6 in combination with the other test as well. So if we talk about the hemodynamics, so what is hemodynamics? It's basically a hemodynamics is then how your blood flow through your blood vessels. So if you talk about the plasma concentration versus the time, you can see here the like IL-10, IL procalcitonin, the CRP, and tumor necrotic factors alpha. These are the markers which helps to diagnose the infection, and then pro-inflammatory markers. In case of the sepsis rule out, you can see that the plasma concentration comes in a early marker in IL-6 case shows the conclusion that the IL-6 is the earliest marker for the infection as compared to the other inflammatory markers. So if we go for IL-6 to help diagnose the sepsis. So basically, it's Accuracy of the serum in interleukin 6 in the sepsis diagnosis, a systematic review, and the meta analysis on the basis of this characterization and data extracted on the basis of the study in the systematic review that the different countries like Turkey, USA, South Korea, and the France, which include the different age factor, the units in the age between 38 to 65, and the newborns as well, the patient numbers having a sepsis, their controls values, and the cutoff values on the basis of sensitivity and specificity with the positive productive values and the negative productive value. The conclusion of this characterization extraction of the study in the systematic review is that the conclusion is, you can see here, the high sensitivity and specificity for the auxiliary diagnosis of sepsis in both the neonates and as well as the adults, right? So this is an early marker for the diagnosis of sepsis in different age groups. So if we talk about the post-operative sepsis situation and the IL-6 correlation, you can see that as we know that the patient undergoing a major surgical resection for cancers are at high risk for post-operative septic complication. So the early identification of patient who subsequently develop the post-operative sepsis would enable the selection of the patient who may benefit from early intensive management, and then this for that. So according to this data, then in the non-septic patient and the septic patient differentiation, that there is a great gap between the non-septic patient and the septic patient only in 1 day after the of post-operative sepsis situations. And in this box, you can see that the IL-6 level on a 0 day and the first day is a non-septic is a number of 34 patients. And then the septic patient having a 16 patient have a compared with the non-specific samples, septic patient that shows that it's remarkably raised in that patient. So, so if we go for prevalence of for rheumatoid arthritis, sorry. So if you go for IL-6 post-operative sepsis tables, so in this post-operative sepsis tables, according to the basis of sensitivity, specificity, and positive, negative predictive value, and under the curve or area under the curve for the C-reactive protein, procalcitonin, and IL-6, the conclusion is that the under the curve value for the IL-6 is 82.1%. So you can see that, which indicates a better sensitivity and the specificity for the IL-6 to help diagnose the sepsis compared to the procalcitonin and the CRP value. So this is more important in such cases as compared to the other markers like CRP and the procalcitonin. Their area under the curve of the 95 percentile is much, much better than as compared to the CRP and the procalcitonin markers. So if we go further for prevalence for the rheumatoid arthritis, you can see here the rheumatoid arthritis is the second most common cause of arthritis, and this is autoimmune disease. So in this autoimmune disease, they have a immune response, and it's affect approximately 1.3 million people in the USA, and about 70% of the patient who have disease are women. And the rheumatoid arthritis develop during age between 30 to 50 years, but it can only occurs at any age, maybe also that can be occurs. So in the prevalence of the rheumatoid arthritis, which is autoimmune disease, this assay is very clinically significant for the prognosis and as well as for the supplemental testing for the inflammation marker in rheumatoid arthritis as well, along with the RA factors or CRP analytes. So if we talk about the clinical utilization in RA, the persistently elevated IL-6 is associated with the several systematic manifestation of the rheumatoid arthritis. And you can see that the increased cardiovascular risk in the fever and the fatigue, it's stimulate the circulation of IL-6 along with the initial marker of a fever and fatigue of IL-1. And then in the bone osteoporosis case and osteoclast activity increase due to this IL-6 levels, and then the acute phase of reactants productions, and then in the bone marrow anemia and thrombocytosis are also one of the impact of the IL-6, elevated IL-6. So these all lead to the systematic inflammation acute phase response, and this is due to the circulation of increased levels of IL-6. So the IL-6 is synthesized and secreted by the immune cells and the synovials of inflamed joint, including the FLS and the monocytes, macrophages, and the neutrophils as well. So if we go for a further for about the diurnal variation, as you know that the diurnal variations, samples were taken for a different time duration and it's behaved with a different values and a different time period. If we compare the value of diurnal value in the picomoles per liter and at a different times when they collect the samples at every hours over 24 hours period, they have a 32 exaggerated circadian variation with respect to the amplitude and timing in the serum IL-6. You can see here that was seen in the patient with the rheumatoid arthritis when compared with the healthy subject. This data shows that the serum IL-6 level significantly increased and were it at their highest in the early morning. So you can see that in the early morning, the values are highest. So the sample taking every 24 hours and they have elevated values. So the data shows that the significant increase in the high level in the morning level. So the diurnal variation in plasma IL-6 concentration in normal five subjected in five normal subject and the five rheumatoid arthritis patient. So there's a one more thing about the analytes clinical pre-analytical factors that the samples, if we are taking blood samples for the IL-6 monitoring, the sample should be taken in a anticoagulant tube like EDTA tube, and the centrifugation is recommended within the 30 minutes because it's comparatively less stable analyte. So after immediate centrifugation, if you want to run the samples, you have to run the samples, the sample of the plasma sample for IL-6 within the same day, or otherwise you can refrigerate it, and within the 24 hours, you can use it. Otherwise, if you are not want to run the analyte within 24 hours, you have to freeze it, and it's up to stable up to the in some books it's recommended up to the 3 months the analyte is stable at minus 20 degrees centigrade. So the analyte is very sensitive, so you must be careful about when you are using it. So if we talk about the normal values, it's usually not in the bloodstream, it's not in a significant amount, but when you have a compare with the normal, it's between 0.0 to 7.0 nanogram per ml, and it's up to the 18 nanogram per ml values are considered as normal values. And if we want to check the systematic inflammation response, that the cutoff value is 80 nanogram per ml. So according to the guidelines, if they have a value of 80 nanogram per ml, higher than this, that's the it's immediate medical attention is required. That maybe leads to the severe sepsis or the septic shock. So if we compare the IL-6 assay of SNIDE versus the competitors, you can see there we have a two generation, the generation 1 and generation 2. Both are quantitative analytes as compared to the Roche. The measuring principle is based on the sandwich technique as compared to the Roche as well. We have a sampling volume 100 microliters as compared to 30 microliters, and both the sample types are recommended, serum and plasma. So the ideally recommendation is the plasma. That's an EDTA plasma is an ideal sample recommendation, and the immediate separation of plasma from the whole blood to perform the test within 24 hours. Otherwise, it is recommended to store at minus 20 degrees centigrade. So the measuring range we have in our first and second generation is up to the 5,000 picogram per ml as compared to the other competitors, which is equally good. If we talk about the limit of detection blank and the quantitation, our quantitation is at 3 picogram per ml which is better than the competitors, and the calibration interval is 1 week. And the 1 week is about, or other competitors have a 1 week or 28 days in case of the lot calibration. So if we go for a comparison of SNIBE IL-6 as compared to the other competitors in the market, we have a regression value of 0.95. And the number of test runs that of the all ranges between 10 to 3,000 picogram per ml. So the excellent correlation shows that our assays is equally good as compared to the other competitors available on the market. So the next question is, why choose IL-6 of SNIBE? So as compared with the procalcitonin, the IL-6 has a higher sensitivity and specificity. The first reason why we have to choose IL-6 of SNIPE. And in compare with the CRP, it's an earlier sign of sepsis. So it is more clinical utilization as compared to the CRP, but it's in conjunction with the CRP and clinical finding. The IL-6 is a highly specific marker or a pro-inflammatory marker in such cases of autoimmune disease, in such cases of carcinoma and coronary heart failures and stroke condition. So we have a very comprehensive test menu, and it's a very big market about that. So if we talk about the measuring range, we have a measuring range between 0.5 to 5,000 as compared to the other competitors, which is equally good. We have a lower detection value, which is called a limit of quantitation, which is much, much better than the other competitor. We have a free calibrators and two level of QC along with the reagent. As compared to the other competitors, they have to purchase separately the calibrators and the controls along with that reagent. So this is the reasons why IL-6 is important to choose NIBE. So let me share with you one more interesting thing about IL-6. So I have to go for something for you. Says okay. Now you can see my screen. I hope you see my screen because I've just checked it. Right. Okay. You can see my screen. Okay. So you can see here. So if we talk about the SNI Meglumi IL-6, the important information is about the test pack size. We have 100 test pack size and the 50 pack size. And this assay is a quantitative determination of IL-6 in serum and plasma. This is important. And as you know that the interleukin is a cytokine, and cytokines are protein in nature, and they have a wide variety of biological functions. It's basically stimulate the beta cells and the T cells to produce the interleukins, and these hybrid hormones, growth factors, and hepatocytes stimulating factors, and many others. And basically, the IL-6 is also produce some gene encoding of 212 amino acids, and then it's also have a molecular weight of 22 to 27 kilodelta. So it is also produced by the fibroblast, monocytes, and the macrophages as well, and the T cells and beta cells, epithelial cells along with that, and neoplastic cells with interleukin 1 and the tumor necrotic factors alpha. So this is the clinical utilization in terms of assay linearity, and let's talk about the type of the cell. So if we talk about if you want to check either this is a one-step assay or a two-step assay, the each assay has a principle of the test. So if we go to this principle of the test, you can see here. So you can see that the IL-6 is an sandwich chemolysis immunoassay. And this is basically what happened. It's an sandwich principle, and it's an anti-IL-6 monoclonal antibodies and the microparticle coated bodies of anti-IL-6 monoclonal mixed together with the sample and then incubate. After having a sandwich, the precipitation in the magnetic field and supernatant is decant and the wash cycle is performed. So then the starter 1 and 2. So here the steps helps you to check whether this is a one step or a two steps. If I talk about the stepwise, this assay is a stepwise. This assay is a one step assay. You can see that there is only a one washing. That's why it's a one step assay. So if we talk about the analytes, if we talk about the analyte components, we have a microparticle beads and the calibrated low high buffer ABI label and the dilute as well with the control 1 and control 2 for the patient runs to verify the patient's reliability. So then if we go to the standardization of our assay, you can see here, according to the traceability and standardization procedure, we have a NIBSC, that's a code of 89548. And this test is, we have a 2-point calibration along with the master calibration of the whole is based on the RFID barcode. So whenever we need a calibration, if the reagent pack is used more than a 1 week and it's a control lies outside the expected range, or if you have done a major maintenance of instrument, so you need to run a QC, and then the QCs are recommended for that. So this is most important part for this area is the specimen collection and preparation. The serum standard sampling tubes, either dipotassium EDTA or tripotassium EDTA is ideal for the sample collection. And you have to ensure if you are using a clot tube, that's a clot formation should be ensured before going for a centrifugation. And after that, you have to check the hemolysis, lipemic, and entericness of the samples, and you have to run within the 24 hours after certification, and certification should be done within the 30 minutes. So the all samples can be tested within 3 hours when placed on board on the Meglumi. This is the important information. If you specimen removed from the separators and the salts or the clot, you can store up to 24 hours at 2 to 8 degrees centigrade and stored at 12 weeks for frozen at minus 20 degrees centigrade. So this is the camp sample stability at minus 20, 2 to 8, and at a room temperature. So once you have used this, then you can store it at according to your requirement or retention policy. So if we talk about the storage and stability, the open at 2 to 8 is minimum stability is 6 weeks. So according to the workload that customer can be order the interleukin 6 reagent because the onboard stability is 6 week. If you want to enhance the onboard stability of this IL-6, you have to store the reagent whenever you want to run the patient samples. Every time when you put the reagent on board, it may meet the onboard stability of 6 week. But if you keep the reagent on board, whenever you need a patient samples wants to be run, because our instrument has a edge of advantage of a continuous sample and the reagent loading. So you can load the reagent whenever you want to run a patient samples. You can enhance the 6 week onboard stability of our reagent. So the minimum stability is on board is 4 weeks at 2 to 8 degrees centigrade. 2 to 8 is 6 weeks. So 4 to 6 weeks is guaranteed in terms of open bile stability of the reagent. So if we talk about the preparation of the reagent, the resuspension of the magnetic beads take place automatically when the kit is loaded automatically. So there is no manual procedure. Just you have to make sure that the reagent is loaded at least 30 minutes prior to run the patient samples, because it's taken 30 minutes to mix the microparticle beads. And then if the samples who have above the 50,000 picogram per ml, the measuring of these analytes may be diluted with automatically by analyzing or the analyzers. So with that, and the recommended dilution for the high value of result is 1:9. So if the result is still higher with the 1:9, so the customer can use an automatic dilution or a manual dilution procedures, but the system has the capability of automatic dilution, so they can perform an automatic dilution as well. So there is no high dose Hooks effect were observed having sample up to 200,000 picogram per ml. So the important thing about the interpretation of the result, the reference range of IL-6 and SNIME is less than 7 picogram per ml. But according to the epidemiological distribution of each country, and each lab should establish their own reference ranges. But according to the healthy individual in China, 275 patient has been tested, journal healthy population has been tested, and the reference range is less than 7 picogram per ml. So the results may also differ with the laboratory to variation. So each is recommended to establish their own reference ranges if the laboratory has some discrepancy in the reference ranges. So if we talk about the IL-6 assay limit of blank and limit of detection and the limit of quantitation, that we have a 0.5 limit of blank, 1.5 limit of detection, and the 3.0 is a limit of quantitation. So for the lower linearity, usually the labs prefer to use a limit of quantitation. In some cases, the labs are using limit of detection. Otherwise, it is highly recommended to use the limit of quantitation as a lower detection limit. So the measuring range we have considered is between 0.5 to 5,000 picogram level, which defined by the limit of Bland and maximum of the master curve. If the result is less than 0.5, you have to report as less than 0.5. But if we use the limit of quantitation, then results is, if the less than 3, it should be considered as less than 3. So if we compare with the reference ranges, it's the less than 7. So if we use the limit of quantitation for a lower detection limit, if its result is less than 3, you can, it's under the lower than the lower the cutoff of IL-6. So that's why you can use that. So according to the method comparison and the analytical specificity for that, up to this concentration, it shows that this is a good in a analytical concentration for that. So if we go for further in this package insert, you can see there is the endogenous interferences and the references that they are using. So I have a one more thing that we would like to share with you. Just give me a 1 minute so I can share with you one important video, which helps you a lot, which is other than this training material, but it looks good. So,
video we are going to discuss about
excuse me.
IL-6 test and its significance. What is IL-6? IL-6 is the interleukin 6, which is a cytokine that is going to be released during the immune response. And this IL-6 is responsible for the development of acute phase response. This acute phase response leads to systemic inflammation. So IL-6.
So the voice is clear for you, guys? Anna, Irina, is our voice is clear for you? Okay, thank you.
Acts as a marker for inflammation. During the immune response, three important cytokines are going to be released, which can develop the inflammatory cascade. The first one is the IL-1, interleukin 1, which is actually responsible for development of hyperthermia, that is fever. And second one is the IL-6, which plays a key role in the inflammatory cascade. And third one is the TNF alpha, tumor necrosis factor alpha. These three cytokines play a crucial role in the immune response, and they are pro-inflammatory mediators. So today in this video, we are going to discuss about the role of IL-6 during the inflammation and in which conditions it is elevated and how it is detected and what are the normal values. When IL-6 is elevated, as we have discussed earlier, the elevation of IL-6 levels is associated with the immune response. So in case of any systemic infection, it can lead to the stimulation of immunity so that the T cells are going to be stimulated. And these T cells can release few of the mediators which produce the systemic inflammation. Similarly, in few of the conditions like the autoimmune disorders, for example, rheumatoid arthritis and SLE, systemic lupus erythematosus, again, there is an auto-stimulation of the T cells which enhance the inflammatory response, resulting in the systemic inflammation. Similarly, if you have the cardiovascular disorders, for example, cardiac cells are damaged. In the cardiac damage, such as congestive heart failure or any associated conditions like the stroke, again, in such conditions, we can observe an increased inflammation within the body. And not only these conditions, if you have the chronic disorders like the cancer, within the microenvironment of the cancerous cells, inflammatory mediators are going to be released, which results in the systemic inflammation. So all these conditions are associated with the inflammation where the IL-6 levels are elevated within the plasma. So it can also be elevated in few of the inflammatory conditions like asthma, inflammatory bowel disorder. So wherever there is a systemic inflammation, there may be elevated levels of IL-6, which indicates the severity of the inflammation within the body. Now let us see how it is released. One of the important stimulation for the IL-6 release is the immune response. So whenever a viral infection or any other type of infection, they inject few of the foreign bodies which are act like antigens. These antigens can be recognized by few of the cells which are called as APC, antigen presenting cells. So these antigens can bind to this APC, and once they are bound to APC, the antigen presenting cell can digest these antigens, resulting in the fragments of the antigen. These fragments are represented by one of the expression molecules which call MHC2, major histocompatibility 2 complex. Now, these fragments of the antigen can be presented by MHC2 molecules, which are recognized by CD4 T cells. In this way, the antigen can stimulate the T cell activation, and these CD4 T cells can release one of the important mediator, IL-2, interleukin 2. Now, this IL-2 can stimulate and promote the T helper lymphocyte 0. This T helper lymphocyte 0 can be split into two components by various types of other cytokines. One of the wing is the activation of Th2 lymphocytes. These Th2 lymphocytes can activate the B cells, and these B cells are converted into plasma cells, which release the IgG antibodies. In this way, whenever antigen is presented, the immune response is going to be stimulated to release the antibodies against this antigen. At the same time, these Th0 lymphocytes can also be converted into Th1 lymphocytes, which are going to release the memory B cells. These memory B cells will capture the memory of antigen, and they can release the antibodies within the future whenever the host is injected with these antigens. So this is the one division of immune response where the CD4 T cells are activated to release the specific antibodies. So during this immune response from the Th0 lymphocytes, one of the mediator is going to be released, that is the IL-6. Along with other cytokines, IL-6 is also released, but the elevated levels of IL-6 indicates there is an enhanced immune response and progressive inflammation within the body. That's why IL-6 acts as a biomarker for inflammation. And based on the elevated levels of IL-6, we can assess the severity of the infection as well as inflammation within the body. But generally, the IL-6 can be released from the monocytes as well as macrophages, as well as T cells, and even from the endothelial cells. All these are going to release the IL-6, which is responsible for the development of acute phase response. This acute phase response involves the release of further mediators which produce systemic inflammation. Now, the IL-6 which is going to be released can lead to the acute phase response. One of the primary target of the IL-6 is the hepatocytes. From the liver, IL-6 can stimulate the release of the mediators, like one of the important mediator is the CRP, C-reactive protein. Similarly, it can stimulate the release of another protein, serum amyloid A. And it can also release the fibrinogen, which is responsible for the clotting process. In this way, IL-6 can release the inflammatory mediators, which are responsible for the acute phase response. That's why whenever IL-6 levels are elevated, most of the times it is associated with the elevated levels of the CRP. So there is an association between the IL-6 and CRP levels within the body. Whenever IL-6 levels are elevated, CRP levels are also elevated. That's why IL-6 along with the CRP can act as a biomarker for systemic inflammation. How IL-6 test is done? This test is done by collection of the blood from the veins, and the blood is going to be collected in the test tube, which is coated with the EDTA, such that we can inhibit the coagulation and separate the plasma. But after the collection of the blood sample, it should be immediately centrifuged so that the plasma can be separated. The supernatant liquid is the plasma, which is stored for the analysis of the IL-6. Here, one of the interesting point is that the centrifugation should be done within 30 minutes after the collection of the blood sample. So if the plasma is separated after 30 minutes, it may result in the analytical errors in the IL-6 test.
So that's the reason why I recommend the plasma sample as compared to the serum, but they both are recommended. Like you can perform the IL-6 from serum samples as well as from the plasma samples. But for the serum, if you are using a red top tube, which has a no clot activators or a gel between the whole blood, it's naturally required at 15 to 20 minutes to clot in normal samples. But in a renal failure patient, it's very difficult to clot the samples because even in the gel tube, if they have clotting time of 15 minutes or 20 minutes, after that the gel tube of yellow top tube may again contains a clot in a clear serum as well. So this is a challenge for the renal impaired patient. That's why the plasma is the right approach for such analytes who are temperature sensitive, and on exposure they may reduce. So ideally, the dipotassium EDTA or tripotassium EDTA plasma is recommended.
Once plasma is going to be separated, it should be immediately refrigerated, and better it should be stored in a frozen form. And the freezing of the sample should be done within 24 hours in order to eliminate the pre-analytical errors. What are the normal values? Generally, IL-6 is not significantly detected within the systemic circulation. That's why normal levels of IL-6 can be considered as 0.0 to 7.0 nanogram per ml. But generally, the normal level can also be considered up to 18 nanogram per ml. So there will be a slight variability in the normal levels according to the analysis. Up to the 18 nanogram per ml, it can be considered as a normal level. But sometimes the slight elevation of IL-6 values may not be correlated with the systemic inflammation. So always IL-6 levels should be correlated with the clinical symptoms within the patient. That's why if you have the studies, a cutoff value is going to be given to the IL-6 value. Generally, the cutoff value is considered at 80 nanogram per ml. So this cutoff value indicates a severity of inflammation. So whenever this IL-6 value is greater than 80 nanogram per ml, it indicates a progressive inflammation which should be immediately treated. What are the limitations of the IL-6 test? The IL-6 is having very less stability after the collection of the IL. Even it indicates the inflammation. So generally an elevated level. Similarly, whenever IL-6 change. So these are the limitations of the IL-6 in the immune response is going to be formed where excessive stimulation of T cells along with the release of cytokines may result in the systemic inflammation. In such conditions, they will come with another interesting test in our next video.
So you can see that the clinical utilization and in the which condition that the IL-6 has a more information about that. So if we talk about this interleukin, this is about our essay, clinical utilization and that. So if you have any question, you can ask or we can take. Any question if you have? Okay. Okay, just give me 1 minute. So I have to take one. Okay, so you want to take a break for 10 minutes or we have to start a new slide? And I hope all of you have make the copy of this application training final exam link and the feedback link as well. So for those who a little bit joined late, I have sent this application training final exam link and the feedback link. So please make the copy of that link. Otherwise, if we leave that group Zoom meeting, so you will not be able to copy that feedback link and the exam link. So I hope you will all copy that. So you want to take a break for 10 minutes or we have to start a new presentation? Okay, Irina, so let's start the break. And the 10 minutes break is okay for you, or we have to go the same with the 15 minutes break? What's up to you? 10 minutes is okay? Okay, so we will back after 10 minutes. Thank you. So, hello everyone. If you don't have a question, so I have a one question to you. So, what is the difference between CRP and IL-6? So, you have 1 minute. If you have an idea, you can share with us. So, otherwise, I will give you the response. Just little bit think about that. So, what is the difference between CRP and IL-6? Any idea about that? Okay, let me share with you the answer. So you can see here the difference between the CRP and the IL-6 is the CRP is an acute phase reactant which has been used in diagnosis of bacterial infection in neonates. while the IL-6 is a pro-inflammatory cytokine, which is produced by the monocytes and macrophages activated by the bacterial infection. So IL-6 can be detected in blood earlier than the CRP during the course of bacterial infection. So as compared to the CRP, it's an earlier marker. One, one question. So the second question is IL-6 produced by the liver? Anyone can share with us. You can hear my voice. Everyone is receiving my voice right now. If you go to the chat box, I'm sending you some messages. Also, you can also read. If you can read my questions and answers, please write in the chat box. That you can read it. Hello. Okay. Okay, Rina. Thank you. So, is IL-6 produced by the liver? Do you have any idea about that? Okay. So basically, there are subsequent studies which shows that the IL-6 can be produced from an act by the liver, and the IL-6 is well established and important determinant of the acute phase response, which involves the secretion of CRP, serum myeloid A, hepcidin, among other factors from hepatocytes. So yes, there is also produced by that. So if we go to the answer response, I can show you the response in that. Okay. Right? So there is another question. Is IL-6 activate the beta cells? So yes, IL-6 is produced once. It acts as an important stimulant for the B cells, proliferations, and the plasma cell survival and antibodies productions. IL-6 alone can drive further by IgG production from the plasma cell, including anti-double-stranded DNA antibodies. In autoimmune disease, IL-6 can elevate the production of pathogenic antibodies. So this is important. I can share with you this information, right? So this is also a good information about the IL-6. So the last about the IL-6, is this a pro-inflammatory marker or anti-inflammatory marker? It's an impossibility that IL-6 play a pro-inflammatory action in acute inflammation, but also exert an immunosuppressive anti-inflammatory action when expressed at low level. So this is important. Okay. So this is all information about IL-6, what I have, I shared with you. So if you have any comments, it's a good for you or okay. So let's start the next presentation about immunoglobulins. So let me share with you. Okay. So we have a presentation on immunoglobulins. As you know that these are the protein which are produced in response of immune, and then these are basically globulin protein, and which helps to fight against any antigen which comes in the form of virus or bacteria or any other that. So let's start with these immunoglobulins. So we have a four part in this presentation. If we talk about the first part, this is an introduction about the immunoglobulins, and then we will discuss in detail about the four types like IgG, IgM, IgE, and IgA. And in the third part, we will talk about the clinical utilization, some publication, and then the significance of these immunoglobulins in different diseases and the condition. And the fourth part, we will discuss about the SNIPE immunoglobulin assays, which gives you the solution for different disease and different conditions. So let's start with the introduction. So in this introduction, we have about immunoglobulins. So as you know that, so in immunoglobulins, they are basically Y-shape antibodies. Another name is they are called antibodies, and these antibodies are highly specific. They are protein in nature, which are usually produced by the plasma cells when the immune system is triggered, and this immune system is triggered just to neutralize the pathogens like bacteria and viruses. Like bacteria, viruses fall in on any serum when goes enter into the bodies, the immune system responds and produce that body. If we talk about the structure of any antibody, they have a two part, the anterior part and the posterior part. So the posterior part is FAB and FC regions. So that's these regions are some part is fixed and this part is variable, because this specific antigen binding site for the antigen binding side, this side is exclusively for the stimulant of that antigen. So if the antigens are of different types, so the different types of antibodies are produced to capture that antigen and to neutralize this pathogen. So if he goes to the further about the introduction about the antibodies or immunoglobulins. The second name is immunoglobulins. They are classified by the isotypes, and these isotypes are maybe each of it differ in the functions and the antigen responsibility due to the structure reliability. This region is called, they are Y in shape, and this Y shape antigen has a two part. This part is called the FC region, which is a heavy chain amino acids containing proteins, and then these are fixed in nature. So if we talk about the FAB region, this FAB region has a light chain amino acids, and then they have a variable region where the specific antigen binds. So the heavy and light chain, all immunoglobulins have a four chain structures as their basic unit. They have a variable and the constant region. This region is the variable and this region is the constant region, and they are structured in the basic units, and they could be divided into the two region on the basis of the amino acid sequence. So this is called the FC region. This is called the FAB region, and the FAB region is basically antigen binding fragment, while this is a crystalline fragment. So this is about the immunoglobulin. So if we talk about the classification of immunoglobulins, there are five major antibodies which are identified in the placental mammals, like IgA. This shape of IgA is like this. If we talk about IgD, this is shaped like an Y shape. IgG, IgE, and IgM. So they have a different origin and different functions of these five different antibodies or immunoglobulin in medical terminology, we say. If we talk about the typical percentage of these antibodies or immunoglobulin in the serums, if we calculate, Around 75% in our body are antibodies are IgG antibodies. Only 10% are IgM. The IgA are 15%, and IgE in normal condition it's a 0.005%. But if the IgE is higher value in the bloodstream, it shows as some allergic reaction response from the body, and it's a non-specific allergic reaction marker when the IgE level is increased. So if he goes further about the second part about the individual immunoglobulins, and in this individual immunoglobulins, let's talk about the IgM. So basically, it's the largest immunoglobulin. It's a macroglobulin, and this first antibodies to appear in the response to the initial response is a antigen and decline as an IgG production is IgM. So the first marker for any specific disease is the IgM, either HCV or HBsAg or HIV. Both have, if they're going to detect any response, immune response, IgM is the first marker to check the immune response. So the first Ig to be made by the fetus is also an IgM, and it's a useful diagnosis of the infectious diseases, and it's also demonstrating the IgM antibodies in the patient serum, which indicate the recent infection, and it's the newborn serum indicates intrauterine infection as well. So the IgM test for the newborn is to determine whether they have acquired an infection or a congenital by birth, or they have a presence indicate that an infection begin during the pregnancy. So this is about the immunoglobulin M, and then let's talk about the IgG. So the second most common and the most common immunoglobulin after the IgM, the second antibodies produced by the immune system is IgG. So the IgG is capable of having many kinds of pathogens such as viruses, bacteria, and the fungi. They have a binding capacity with them. They have a predominantly act as a secondary immune response, and they have a placental transfer, the only class of immunoglobulin that cross the placenta because of the small size, and they have a providing immunity to the newborns as well. And the IgG, you can see the structure of this IgG, this very complex protein structure due to this amino acid sequence. They have a fall levels falls in the first six level of life as a maternal transplacentally acquired antibodies levels fails, and the premature infant have a less maternal IgG. So that's the immunoglobulin and IgG feedback in the immune system. So if we talk about the four isotypes of IgG, in IgG3, there are four types: IgG1, IgG2, IgG3, and IgG4. You can see here that the Ig3 appears early in a response and join IgM defense in clearing foreign antigen, while the subsequent IgG2 and IgG1 are produced to help to determine the strength of the inflammatory process. Finally, the Ig4 is produced to dampen down the inflammation. So in IgG isotypes, there are majority part is you can see here is IgG1, and the second highest part is IgG2, and then the later on the Ig3 and Ig4, which play their clinical significant roles in different situations. So if we talk about more about the immunoglobulin E, IgE, this is the Y-shaped antibody, and they have a different FAB region and FC region. If we see their microscopic structure of that, they have a light chain and a heavy chain with the bind with the disulfide bridge with them, and they have a variable domain antigen binding site, and so basically prime the IgE immediate allergic response when binding with this FC receptors found on the surface of the mast cells and the basophils, and this isotopes has an co-evolved with the basophils and the mast cells to defense against the parasite like helminths, and maybe also affect in the bacterial infection. So these antibodies play a very vital role in acquiring the resistance to like honeybee and the Russell viper venoms about that. So it's clinically important in terms of that. So if we talk about the immunoglobulin A, which is also an important part in the immune function of the mucous membrane. So there are two types of immunoglobulin A. One is called IgA and IgA2. So the IgA predominantly, which is 80 to 90% of overall immunoglobulin A, and IgA2 takes the second place, about 10 to 20%, while the IgA2 percentage is higher in secretion than in serum, around 35% in secretion, while the secretory IgA found in the maternal milk, tears, sweat, saliva, as well as secretion from the urinary tract, digestive tract, prostate, and the bronchus. So the IgA2 is more important in secretion than in serum levels. So there, this is the clinical importance and then utilization of and the presence of IgA levels in the that. So if we talk about the patient tools, why get tested? To help evaluate a person immune system status, to detect and monitor an excess or a deficiency in one or more of the immunoglobulin classes. So IgG, IgA, IgE, and IgM, they have a samples required types is a serum or a urine. And for the sample serum type, is it is recommended for the IgG, IgA, IgE, and IgM. The urine sample for the IgG and IgA is important, and to determine the deficient IgG resulting from the production disability or protein loss, urine sample is used to determine the amount and type of protein present in the urine. So if the levels of detection of these required, that's the clinical utilization of these assays. The question is when to get these tested this immunoglobulins. So if a person has a symptoms of an immunoglobulin deficiencies like recurrent infection, respiratory or digestive system, or a chronic diarrhea, has a sign of chronic inflammation, parasite infection, or various allergic reactions, or if they have a monitoring condition that immunoglobulin level may have be a genetic selective IgA deficiency or acquired HIV immunodeficiency virus or AIDS, this condition is there. So that's the condition when you have to get for tested for the immunoglobulin test. So if we talk about the interpretation of the increased immunoglobulins, just give me a 1 minute, please. Sorry. So the interpretation of the increased immunoglobulin, if you talk about the interpretation of the immunoglobulin results, like a polyclonal increase in any of the three classes like IgG, IgA, or IgM, there are some associated condition in some cases of infection of acute and the chronic phase, like HIV virus, cytomegalovirus, or some cases of autoimmune disorder like rheumatoid arthritis, systematic lupus erythematosus. These are the cases in which the immunoglobulin, along with the IL-6 and CRPs, are raised as well. And then some chronic active autoimmune hepatitis, IgG. There are some more in chronic inflammatory disorders, in some primary biliary cirrhosis. IgM is level is increased in a newborn infected during the pregnancy, congenital syphilis, toxoplasmosis, rubella, cytomegalovirus. The immunoglobulins levels are elevated. So in some monoclonal increase in one class without decrease in other two classes are also associated with some condition of like multiple myeloma, IgG, IgA, rarely IgM is elevated, some chronic lymphocytic leukemia, that's called CLL, that's the lymphoma, and the Waldenstrom's macroglobulinemia condition in which IgM is increased. In the hyper IgM syndrome, it's a genetic disorder now have an interpretation of increased immunoglobulins levels are observed. So if we go for some publications regarding the uses of the immunoglobulin in infection and infection related diseases. So according to that, the update on the use of immunoglobulin in human disease, review of evidence basis that they're definitely beneficial for some diseases, and the evidence category and strength of all the recommendation is there in some cases. In the probability beneficials, definitely beneficials, there's some cytomegalovirus pneumatitis in solid organ transplant, in neonatal sepsis, rotavirus enterocolitis, bacterial infection in the lymphoproliferation disease, toxic shock syndrome, enteroviral meningoencephalitis. There are cystic fibrosis cases may be beneficial for that. Post-operative sepsis, along with the IL-6 and CRP, that's as a clinical utilization more. In a chronic parvoviruses P19, unlikely to be a beneficial in the chronic fatigue syndrome, cystic fibrosis without hypogammaglobulinemia, in acute rheumatoid fever and the viral load in HIV infections. They have a class of B strength of recommendation of immunoglobulin. So according to the different condition like definite, probable, and may provide benefit or unlikely to be provide a benefit, they have a categorized the strength of immunoglobulin screening on the basis of their recommendation is that. So if we go for about the usage of immunoglobulins in human disease, like an evidence, they have a definitely beneficials in some cases of Graves' ophthalmopathy, some immune thrombocytopenic purpura, in some dermatositis. There are some other condition in which have a probable cause of birdshot retinoadenopathy. So these are the different conditions in which it's definitely beneficial or probably beneficial in some cases. So if we go for the interpretation of decrease immunoglobulins like IgG, IgM, or IgG, so these are the some condition factor that affect the immunoglobulin production. Maybe some drugs such as phenytoin, carbamazepine, or immunosuppressive drugs in case of organ transplant or some other conditions that the immunoglobulins are decreased, and then the complication from the conditions such as renal failure or diabetes also shows that some delay in the production. The newborn, particularly premature infants, has a low value of immunoglobulins. If you talk about selective immunoglobulins, if you talk about the selective immunoglobulins, there is a short delay in the production in the newborn, particularly premature infant. They have a selective immunoglobulins deficiency. Then they have isolated primary immunoglobulins and deficiency. If we talk about the nephrotic syndrome, that's conditions which are cause an abnormal loss of protein and increased catabolism for the immunoglobulins. There's some nephrotic syndrome of a kidney disease in which protein is lost in the urine, in the burns cases, in the sepsis cases, or in the protein losing intestinal disease, any condition that digestive tract that affect the digestion or absorption of protein are also have a cause of decreased immunoglobulin in the human serum levels. So if we go further for a clinical utilization, use of immunoglobulin in primary and secondary immune deficiency. So you can see here some is definitely benefit. It's with the absence of B cells, with the hypogammaglobulinemia and impaired specific antibodies production cases. And then the others have a some variant effect in antibodies quantity and quality as well. If we talk about the probable benefit, That's the CLL with the reduced IgG and the history of the infection, along with the HIV infection in the children, and the primary immune defect with the normal IgG and impaired specific antibodies production are more significant in the probably benefit cause of that. So, if we talk about more the guiding significance for the immunoglobulins levels monitors, so they also indication of the immunoglobulin therapy is the indicated as a replacement therapy for the patient with the PI characterization by absence or deficient antibodies production. And the PI is an FDA approved indicator of immunoglobulins for which the currently available products are licensed. So the diagnosis, if you go to the diagnosis, you can see here the large number of PI diagnoses exist for the IV1 IG. 4 IG is indicated and recommended, and some infrequency of immunoglobulin treatments are has been recommended. So there are some guiding principle issues for different frequencies of immunoglobulin retreatment, like the dose, IgG, throat level, site of the care, route, product, and then on the basis of guiding principle, rationalization is given. So the overall 8 guiding principles for the effective use of immunoglobulin replacement therapy for the patient with the PI. So if we talk about method to distinguish a monoclonal IgG from a polyclonal IgG. So the protein electrophoresis, immunofixation electrophoresis, and serum-free light chain testing, these are used mostly in the lab for immunoglobulins. These are still a gold standard for the confirmation. So if you have a polyclonal immunoglobulins, there is an excess IgG in any or all immunoglobulin class from many different immune plasma cells. And if we talk about the monoclonal immunoglobulin, these are the excess immunoglobulins are from the clone of the one plasma cells. So this is the gel electrophoresis, which is called a protein electrophoresis. That's IgG, IgA, IgN, kappa and lambda chains are also observed with the reference. They have checked with them, and then they can report it on that basis. So if we talk about the follow-up test for immunoglobulin deficiency or the higher than the normal ranges, if we are to go for a follow-up testing, which includes the CBC test, which identify the disease of immunodeficiency, or a flow cytometry to identify of T cells of B lymphocytes using this technique of SALS analysis. If you talk about the salivary or CSF IgA, then the complement component C3, C4 also helps them to diagnose further this immunoglobulin deficiency conditions. So if we go for a further about the SNIPE immunoglobulin assays, so what do we have a 2 generation of immunoglobulins. If we talk about the immunoglobulins, we have IgG first generation and IgG second generation. So if we talk about the first generation, we have a serum and plasma analysis were recommended along with the urine analysis. In the same second generation, we have also all these blood and urine samples are recommended. So the calibration frequency is improved in the second generation of IgG assay on Maglumi series, while the reference ranges is depends on the age, and the reference ranges as the given for the urine analysis, and the assay range is between 3,000 to 80,000 as compared to the urine of 4.0 to 2,000 microgram per ml. So the diluent for diluting the high result, which is also included and in it, and that's in cases you can run automatic dilution as well rather than to use the manual dilution. If we talk about the traceability, this assay of IgG, first generation and second generation is standardized against the WHO standard of 67 slash 086 as compared to the second generation, which is more advanced. They have a standardization against the global guideline. Latest updated is ERMDA 470K/IFCC. So the limit of blank was in 0.2, and now there is a 25 in a serum plasma sample and 1.0 microgram per ml in urine sample. So if we talk about the limit of detection for both serum and urine was 0.4 microgram per ml. But in IgG second generation, the serum or a plasma analysis, the immunoglobulin IgG value is 75 microgram per ml, and urine is a 3 microgram per ml. So if you talk about the IgA, you know that this is the serum and plasma, and in the urine, all these three sample types are recommended. In the first generation and second generation, we have an improved calibration frequency in the second generation up to 28 days. And if we talk about the sample volume, we have reduced the sample volume in the second generation of IgA. If you talk about the linearity, we have improved linearity in serum plasma, and the urine samples as well is equally good as compared to the first generation. If the diluents are included, so are the automatic dilution and uh, the dilution which is required for the manual purpose also can be recommended for that. If we talk about the traceability, our second generation kit is calibrate is traceable or is use the calibration material ERMDA 470K/IFCC for the standardization of that assay. If we talk about the limit of blank, in the previous kit, it was a 0.13. Now, according to the guidelines of the IFCC for the limit of blank and limit of detection and the limited quantitation, our second generation assay limit of blank is 2.5 in serum plasma samples as compared to 0.1 microgram per ml in urine samples. So if we talk about the limit of detection, we have, according to the CLSI guidelines and the criteria for the LOD and LOQ and LOB, we have a limit of detection is 7.5 microgram in serum plasma and 0.3 microgram per ml in the urine samples. So if you have any question, you can ask, or otherwise we have to go for a next slide. So any question? Okay. Just give me 1 minute, so I have to take one. Okay. So let's go to the next slide. The next slide belongs to the immunoglobulin M. So you know that in immunoglobulin M, we have a two generation IgG, IgM1 first generation and second generation, and also with the IgE first generation and the second generation. In IgM, the first generation was recommended only for the serum sample type, but in the second generation, we have a privilege of having a serum and plasma, both sample type, with same with the IgE levels. We have also improved the calibration frequency in the second generation IgM and the IgE second generation up to 28 days. If we talk about the sample volume, we have also reduced the sample volume in second generation of IgM, while the IgE second generation is equally good as compared to the first generation. If we talk about the reference ranges depends upon the age and epidemiological distribution, while the second generation for IgE is also referred to the IFU as well. So the assay range in the IgM second generation is between 100 to 20,000 peak microgram per ml. And then the second generation of Ig is also a 0.5 to 3200 IU per ml. So they have a diluent which is included in the reagent cartridge, and it's a already pre-diluted 1:10 dilution is automatic recommended for the serum and so for the include the 1:3 is for serum and plasma in IgE levels, and the standardization is ERMDA 470 for that. So if we talk about the traceability, and this traceability, this is IFCC. Then they have a WHO third international standard, the traceability. If you talk about the limit of blank is 25 microgram per ml for second generation of IgM, and the limit of blank for second generation is 0.1 IU per ml. If we talk about the quantitation, which is 75, detection is 75, and 0.3 in IgE levels. So here you can see that the limit of detection is 75, but the assay range is between 100 to 20,000. So the 100 is the limit of quantitation. So this is the limit of detection. So if we compare the SNIPE immunoassay comparison with the commercially available IgE assay. So on the basis of 133 patient has been run, you can see the range from 0 to 3000 IU per ml. In comparison with the commercially available IgE, you can see that the regression value is 0.982. So this 0.9892 regression value shows an excellent correlation between the SNIPE Meglumi IgE and the other commercially available IgE assay in the market to run a different range of samples. So this is shows an excellent correlation of our IgE with the other reference assay available in the market. So let's start with the comparison. So the SNIPE, what is the solution provided from the SNIPE platform? That the SNIPE platform gives you a very comprehensive solution. We have all these immunoglobulins available from the SNIPE platform, like IgG, IgA, IgE, and IgM. While the other competitors like Roche, Siemens, Beckman, Abbott Diagnostic, Biomedics, and Diasorin, they have some assay they have and some they are missing. The Roche has only IgE levels, while the Siemens has also only IgE levels, and the Beckman has also IgE levels. They do not have IgA, IgG, and IgM. So if we talk about the architect and Alinity, they have do not have IgG, IgA, IgE, and IgM from the architect I module platform, immunoassay platform. So if we talk about the mini Midas analyzer from Biomedics and Diasorin, they do not have any solution for the immunoglobulin. So as of today, we have a very comprehensive menu for even for the immunoglobulins and then the other analytes that we have. So we have a broadest assay menu in the world. So we have, as of today, 236 analytes, including 152 countries, and the more than 29,500 installation of Meglumi analyzer in the world. So if we talk about, if we talk about the joint test with other immune panels, like drugs monitoring we have there. So if we talk about some other autoimmune panels, we have a very comprehensive panels for the rheumatoid arthritis, IL-6, CRP, and anti-CCP. All these three tests play a very clinically significant roles to rule out the rheumatoid arthritis and the viral and bacterial infection or the sepsis cases in the patient. So also the autoimmune diseases like SLE, like some cardiac coronary heart failure, some stroke conditions. So you can check these markers available. So if you check the immune status after the administration of immunosuppressive drugs or intravenous immunoglobulins, so that's can be done on from the single platform. If they check the status of the newborn to determine the infection, the TORCH comprehensive profile helps them to diagnose, along with the other supplemental testing about the normal immunoglobulin levels, which shows a poor specific response to the vaccine and should test specific antibody response to the vaccine. So if we talk about the inflammation monitors like procalcitonin, IL-6, serum amyloid A, and HSCRP, which is excess or deficient immunoglobulins when having a chronic or recurrent inflammation as well. So in the renal function dysfunction like beta 2 microglobulin, albumin, and NGAL, which has a check protein loss when having a nephrosis or a severe damage of the kidney may occur, that may leads to that. So this is about the immunoglobulins and then about all their assays, clinical utilization. So let's have some uh, more important things about the immunoglobulins. Let me check with the IFUs so I can share with you some important IFUs. So where is the So we have for each analyte, we have two kits. Like for IgG, let me share with you my screen. Okay, so you can see my screen for the serum analysis. So you can see here we have a 100 test and 50 test pack size. If the laboratory wants to use a serum analysis, we have a different kit. So you can see here, this is a different kit, 130208005. So if we want to run a urine samples, so this is the urine samples kit. So you can see now the urine samples kit, right? So we have a two kits. One is the urine sample. So first read the urine sample kits. So this kit is used for the quantitative determination of immunoglobulin in human urine using the Maglumi series analyzer. So this is very much important. We have a flexibility for having IgG detection in urine and the plasma both, but both kits are separate. Please make sure that. So if we talk about the assay principle, from the assay principle, you can check either this is a one-step assay or a sandwich assay or competitive assay. The first thing that which you have find this. You can see that here. This is a competitive chemiluminescence immunoassays, right? So this is a competitive immunoassay, and then you can see that labeled with the purified antibodies, and then they mix thoroughly, form after precipitation. This has been declared, and then voice cycle. So this is competitive and one-step assay because only so only they have one step, the only one washing. That's why we call them a one-step assay. And there is a competitive assay. That's why this is one-step competitive assay. So if you see here, the material which is available with that, you can see the magnetic particles, calibrator low, calibrator high, FITC, and ABI, and the dilute they have along with that. So the calibration, quality control, a specimen, and then they have some guidelines has been given for the storage of the specimen in the specimen collection and preparation period. So it's also recommended for some other things that they are recommending in this area is for the storage and stability of the reagent up to 4 weeks, and on board is the 1 month stability for the reagent. And for the preparation of the reagent, only the magnetic microparticle beads need to be mixed thoroughly as compared to other competitors. If they have a urine kits, they need to be prepared. So the dilution, there is an also recommended dilution is 1:5, which is either automatically by the annual or the manual. And then the sample are concentrating above the measuring gland can be diluted. So this is the urine samples information. So if we talk about the serum, so if we talk about the serum, you can see here, this is for the determination on human serum. So the principle of the type is serum only, and this package insert is for the first generation. In the second generation of IgG, we have a recommendation of both serum and plasma. So this serum and plasma has an principle of having a competitive chemiluminescence immunoassays, and there's a one step you can see in the principle of the test that there's only a one washing. That's why we call them a one-step assay. So you can see here the below there is a reagent compartment. They have a filled with the different volume on the basis of 50 tests and 100 test reaction material required but not provided. The reaction module, starter, wash concentrate, light check, and the reaction cups are the required but not provided with the reagent. The calibration we over that we have a standardization or traceability of our method with the WHO first international reference preparation of 67/086 method. And we have a quality control recommendation for the IgGs according to the global guidelines. And when we have to verify that, this is the recommendation. So specimen collection and preparation, warning and precaution for the user, and the storage and stability with the test procedure is also recommended here with the dilution and limitation and the results. With the performance characteristic of the within run and between the run means simple and complex precision and overall coefficient of variation and standard deviation base. They have also calculated the limit of blank, limit of detection, and the measuring range with them. So the limit of detection and limit of quantitation is also there is 0.2. So that's why they are using that. Their analytical sensitivity on the basis of run of different samples, they have also shows you that in this graph. So this is about the IgG package insert. If we talk about the IgM, we can discuss it there. If we talk about the IgM, yes, we have a simple IgM analytes, which is used for the human serum with here. You can see here they have immunoglobulins in the human serum, and this immunoglobulin is a competitive chemiluminescence immunoassay, and this is basically a two-step assay. That's why they have two times washing in it. And then if your calibration frequency is and the standardization of our IgM assay against the first international reference preparation of 67/086. So this is about the calibration about that, and this is the quality controls requirement for that, and this is about that. So if you have any question, you can ask. Otherwise, we have to share with you some more. Any question about that? Any question? Okay, Rina. Thank you. So if you go further, the dilution in the package insert, because this is the first generation, that's why the serum is only recommended, while for the second generation package insert, the serum and plasma both are recommended. If we talk about the dilution, that's 100 times by analyzer in the reagent kits are also there. So you can run that diluent for the dilution for the high results as well. In this essay, you can find the limit of blank detection and the measuring range, along with the method comparison, analytical sensitivity, and the endogenous interference about that. So this is very comprehensive information in the package insert. If we talked about the IgG, IgM, and if we talk about the IgA levels, if we talk about the IgA levels, we have a, serum and the urine different analysis. So you can see here this is the package insert about the IgA levels. So the best thing is about here is that for human serum using the Maglumi series, they have a principle about the competitive chemiluminescence immunoassay, and they have shows you the incubation and then added to initiate. There is only one step assay because this is contain also FITC, ABI, and the dilute as well inside that. So the quality control recommendation, the specimen collection and preparation, and the stability on a different temperature up to 228 to -20, and then the removal from the separator is recommended for that. The storage stability also shows you the maximum stability is 4 weeks guaranteed on when open at 2 to 8 degrees centigrade or when they put the reagent on board. But you can enhance the onboard stability by keeping these reagents on board only for the purpose when the test need to be recommended. So if you less keep the exposure of these reagent on board, that will enhance the onboard stability for that. So we have a limitation, results interpretation, and the reference ranges of have expected value of IgA in different patient samples. That's about IgA level. So we have also a package insert for IgE and IgA's urine package insert is also separate. So if we talk about the IgE levels, so you can see here the IgE levels is here. You can see that it's a human serum and that all information about the dilution, limitation, and the quality control with the assay principle of the showing that this is a sandwich chemolysis immunoassay process having a one steps process. So the calibration traceability is against the WHO reference material of 11/234 is in this assay, and the quality control is showing that about the specimen collection and the preparation. So we have the immunoglobulins, all package inserts available on the sites that can be downloaded and can we do that. I have one more information about you. Let me check about that. If they have a this, so we can share with you one more time. Let me share with you one thing. This is I have a quick Barish. Essay summary. I share with you this essay summary. So this is very difficult to see in this small protocol. You can go to this way. So if we talk about immunoglobulins, we have to go to further infection, tumor marker, titers. So here we can find the immunoglobulins, right? So this is about here you can see that, right? IgE, IgM, IgG, IgA, IgA urine, and IgG in urine samples. So this is the reference ranges or linearity of the assay, or reference ranges of the assay, and this is the linearity of the assay, onboard stability, and the sample volume, how much is required for these assays. So this is about the immunoglobulins. If we talk about the inflammatory marker, that's an IL-6. Let me check with you. Uh, inflammatory marker, infectious, tumor, bone, like this. You can see here. Okay, so here is an example of inflammatory markers. These are the CRP, procalcitonin, and IL-6. And IL-6 cutoff is less than 7 picogram per ml. And the measuring range is 0.5 to 5,000 picogram per ml. 1 week is the that, and 100 microliter sample volume is required. So this is important about the analytes that what we have shared with you. And if you have any question, you can ask, or we can share with you one video for immunoglobulins. If you don't have any question, we can go and share with you something for immunoglobulins. Any question? So let's have some video. Just give me a few minutes because net service is a little bit slow. Just give me a few seconds. So I have to choose the right for more information about the immunoglobulins. Okay. So if I go to the again. So, okay. So I'm not finding any good video for the immune systems and then for the immunoglobulins. It's all basics. Otherwise, I can share with you some other information. There's a one video which is gives you how these immunoglobulins are produced. If you want, I can share with you. So it's a good video. So if you allow me, so it's other than the content, we have still time. So we it's in a 15 minutes, 14 minutes video. Then if you like, then I can share with you. Otherwise, according to the agenda, we have completed the immunoglobulins and IL-6 completely. So what's your suggestion as a team? So you need a one video which gives you the more information about the immunoglobulins, the immune response, and the immune system about that, or you want to finish it right here? What's your recommendations as if I ask as a team? Because we have still 30, 38, 39 minutes more. Irina, Anna, Malia, Ahad, any other one? Urine, you want to see this video or just the overall the immunoglobulins introduction and their clinical utilization and the comparison with the IL-6 is completed as of today. So what you want? You want some more information or we can stop here? It's up to you. Any feedback? Yvonne, Malia, urine comparison. You want to discuss Artem urine comparison of immunoglobulins? Okay, so comparison with the competitors, we have comparison with very few. If you go to the presentation, let me share with you the presentation again. You can see here, if we talk about this is only a comparison here. So you can see here the comparison with only the Roche, Siemens, and Beckman. They have IgE levels, while the IgA, IgG, and IgM there's not available on automation of Siemens, Roche, or the Beckman, or even with the Abbott Diagnostic L&T systems. So there is no comparison with the competitors in the immunoglobulins. So this is basically an edge of our assays as compared to the other competitors. So that's the reason why we have a higher number of analytes and their clinical utilization. So this is about the immunoglobulin. So let's share with you that important video, and then we will see, right? So let's start with the video.
In this animation, we want to show the human immune system with images never seen before. We will learn how macrophages, as well as other cells and mechanisms, protect our organism from death every day. Our skin, like the bark of a tree, represents valuable protection. However, the skin is also home to countless microorganisms. Among other things, they are nourished and protected by an oily fluid called sebum. Sebum is produced by sebaceous glands. Sebum also contains antimicrobial elements that can kill microbes. If they are harmful or too many microbes on the skin, the sebum is composed in such a way that these microbes are killed. This creates a harmonious coexistence between skin cells and microbes, a kind of symbiosis. These microbes also keep one another in balance and kill pathogens that can be dangerous to our cells. The protective layer of hollow organs, such as the nose, mouth, and trachea, is a mucous membrane. Mucous membranes possess cilia. Cilia move back and forth in a wave-like manner. This allows them to move mucus, to which foreign substances adhere, upward into the oral cavity. Ciliary clearance is not sufficient. An attempt is made to achieve clearance of unwanted particles through coughing. This is done by inhalation, followed by a sudden exhalation, so that foreign substances are removed from the lungs and trachea. The bone marrow has stem cells. It is the birthplace for many different immune cells, which we also call leukocytes. Stem cells divide to form daughter cells, asymmetric or symmetric. Symmetric cell division results in either two stem cells or two progenitor cells, as seen here. The progenitor cells divide again and again. Thus, a single stem cell becomes many immune cells or leukocytes.
So this is basically an immune response
And the
video.
lymphoid organs, naive.
Basically, this video belongs to the immune systems, not for with the immunoglobulins. So there are videos which are not impressive for the immunoglobulins more. But if you have any questions, you can ask. Otherwise, we have to close this call for today. And we have also shared some link. If you have copied that link, it will be good. Otherwise, yeah, this is an exam link and with the other link. So, urine. So how good are these? Okay. So Artem urine, there's a one question. If you compare the immunoglobulins results like IgE with the Bachman, so do they have a IgA, IgG, and IgM on the Bachman axis instrument? because the SNIBE menu for IgA, IgG, IgM, and IgE is very comprehensive as compared to the other competitors. So the my question is, did they compare only the IgE level? Okay, IgE levels, right? So in the IgE levels, they are more confident on the Bachmann Coulter axis instrument as compared to the SNIBE. So what is the issue they have observed in IgE level? There is a low trend, high trend, or erroneous results. So what was the difference? What was the reason that they feel that the Beckman Coulter results are most accurate system? How they identify that this is most accurate system? Because if you have a result on one automated instrument, if you have a result on second automation instrument, you have to go for a confirmatory test for IgE. The effect of other blood component on the results. Okay. So urine, did you report these comparison report to the SNIBE headquarter? Because this is most important for the R&D purpose. So if the R&D knows that, if they have any deficiencies, they can work on and that reported this issue. Okay, no document or schedule have been preserved. So okay, so urine. If you have the data, you can share with me. So, because in different clinical situations, it is not necessary if you compare it with the like the CBC, the neutrophilia condition, leukocytosis condition, or some other condition in which the IgE level with the other hematological markers are increased. Okay, that you have conducted this research in 2021. So it is our responsibility as an ethically and then in the field of diagnostic market to update the R&D that they have observed that deficiency in the product, because the quality is in a continuous improvement process, and it's cannot say that as of today where we are we will still here in the next couple of years. No, the quality is a continuous improvement procedures. Once they have identified that the research and development person, they need to be evaluate these assays, reevaluate that to check the sensitivity and specificity of the assay. So the urine, what is the journal perception for SNIBE IgE assay? And to be honest, you have to check whether this IgE was a first generation or a second generation. You can see my screen. If you have done this I can show you my screen. It's my request to you, if you have current So you can see my screen. Here is that in 2021, they don't have a second generation of IgE. So if you maybe there's some deficiencies in the IgE in terms of standardization or some other reason you can see, maybe some have some traceability or some other issues. So now they have a second generation IgE, that is serum and plasma both is recommended. You were using the serum type only, and then they have a reference ranges for the IFU recommended. So please, you have to reconsider the second generation, which is the latest generation of IgE, for the evaluation and a comparison with the reference instrument of the Beckman axis. It will really helps you to check the performance of the latest generation of our assay. Okay, okay. So now it's the best time. You can introduce IgE second generation in your population based any lab, reference lab they have, and they can use this second generation assay, because you know the traceability of our IgE second generation is according to the WHO third international standard of 11/234, which is the latest and updated one, and this is recognized globally. The second thing is, if you have any proficiency testing in your country, like RICAS, if we go to some here, so if you go for some proficiency material in your country, like RICAS, ICAS, or some may have some using the cap samples. So they can use these proficiency testing to check the performance of IgE levels. So this is also an evidence that our assay is equally good as compared to the other competitors in the market, because we have a very comprehensive menu for IgA, IgG, and IgM. So I have a no actual comparison data, but we have in the next few slides, we have a commercially available. Let me share with you. So this is the SNIPE IgE first generation comparison with the IgE or commercially available IgE. You can see that the overall regression value on the basis of 133 samples, you can see here. On the basis of 133 samples, the regression value is 0.989. So slightly lower trend maybe you have observed in your internal study, but the second generation, was the first generation, but the second generation is better than the first generation in terms of results, assay linearity, in terms of some other factors. Like if we go back here, you can see here there is some more edge of IgE versus the first generation in terms of limit of quantitation, limit of detection. And it's also, this is important that the reference range here that was defined as 1 to 190 IU per ml. But now it depends upon the age. It's referred to go for a IFU. So my recommendation is, if you have any opportunity for the IgE, a second generation in your population, you can go for the second generation rather than the first generation, because now the second generation is much better than the first generation. So it is better to go for a second generation. Okay, so check with this. So what is your question? So the current gold standard for assessing the allergen specific IgE in a plasma or serum sample is the immunocab specific IgE test. And this allergen of the interest react with the enzyme label IgE specific antibodies, resulting in measurable fluorescence reaction. So the gold standard is a immunocab specific IgE test. But right now, the clinical findings, along with the patient history and the elevated levels of IgE, which is a very non-specific allergen test, and that's proven if the in case of even the asthma or some other viral infections, that's IgE levels also increase. So the gold standard for that is the immunocap specific IgE test, and along with that IgE test with the serum and plasma, they are going for some other food allergen test, because usually if the people have some allergic reaction, usually the environmental allergen factors or some rhinosinusitis situation, some pollens in some countries, and some people are have a pollens allergen. Some have some insects, some mites, some cockroaches. Some have a allergic reaction with some proteins, like some are allergic to albumin protein. Some they have some, so that still they have a consider be a gold standard for the this is the skin test is also another gold standard for the vivo test used to demonstrate IgA mediated sensitization in the patient and represent a major diagnosis tool in allergology. So the basically IgE is an allergen test. In allergology, the main second function is the skin test, which is the main in the vivo testing. So this is all about the allergen test and their supplemental testing information. So any other question if you have? Okay, if I ask you one question, is this presentation that I am sharing with you and I am in the information that which I have sharing with you, is it okay? The pace is okay. My speeds are okay. My words and the delivery of the my comments are okay. Or you need to make myself a little bit slow. Everything is okay during the presentation, or you want to improve, or if you have any suggestion, you can put it in this comments, right? So again, I'm sending you that link. Please copy, and in the next 2 or 3 minutes, we will leave, right? So if you have any question, you can send me later, or if you want to ask, you can ask right now. Okay, thank you, Jordan. When you copy, if anyone wants to leave, they can copy this feedback link and the exam link, and they can leave, right? Thank you very much for being with us, and have a good time. Have a nice day, rest of the day, and take care of yourself, and bye bye. So if you have copied that link, you can leave, right? Thank you. I will leave in the last. Okay, thank you. Thank you very much. Bye bye. Take care of yourselves. Okay, if you copy, please leave, or otherwise I will left in the next 2 minutes.